and this what leads to الحقيقة الريتراكشن بوكت. طبعا في الاندوسكوبيك اير سيرجري دلوقتي في حاجات تانية زي الميكوزال فولز الحقيقة بتعمل نوع من الكومبارتمنتال ديسفنتيليشن. فدي مسألة برضه we have to take it into account. It's not just the eustachian tube that would lead to this ventilation, but also the compartments and the mucosal folds, such as the ospicus والanticus pouch. يعني. لكن الحقيقة not all the patients with chronic otitis media would develop into atelectatic ears or would lead to retraction pockets. Some of them do, not all of them, for various reasons. يمكن أكثرها الحاجة اللي احنا قلنا عليها الكومبارتمنتال issues. وزي ما حضرتك بتشوفوا إن retraction pocket it may be just a pocket which is a localized area of retraction on its own والباقي كويس أو maybe part of diffuse retraction بس في حتة weaker than the rest ف it looks like a retraction pocket. الحقيقة في ليه ناس عندهم eustachian tube dysfunction يجي لهم pockets to atelectasis وناس تانية ما يجيلهمش. This is a matter of controversy والحقيقة ده بنشوفه in practice. Could there be a genetic predisposition? Does it have to do with the severity of eustachian tube dysfunction or the mucosal folds issues? These are the questions that remain unanswered. لكن الحقيقة يعني we cannot really overlook or forget in the situation بتاع البوكيتس بتبقى indicative of a pathology in the middle ear, which would lead to tympanosclerosis and the consequences of that. في كتير جدا حاولوا يقسموا الريتراكشن بوكيتس منهم سادي والبركو وتوس طبعا في الدنمارك من الناس المشهورين قوي ويحاولوا يعملوا staging للريتراكشن بوكيتس عشان احنا as clinicians we know how to deal with the condition. Stage 1 when the tympanic membrane is retracted but the annulus is visible, and then goes to stage 2 which is essentially you can see that the tympanic membrane is kind of like plastering on the inclusostapedial joint وبعدين بنخش بعد كده في مرحلة الاتلكتسيس والادهيسيف اوتايتس ميديا. زي ما حضراتكم شايفين في الرسمه دي different stages of retraction pockets. طبعا في مرضى بنشوفهم بتلاقي التمبانيك ممبرين is like a jacket يعني لابس الميديال وول اوف ذا ميدل اير على البرومونتري وعلى الاوسيكلز يعني resemble like a jacket بالظبط. ده ديسكريبشن كويس في الحقيقه وده احنا بنشوفه in clinical practice and we need to deal with it. طبعا زي ما انتم شايفين سكيليتونايزد الميدل اير كلها بالبرومونتري بالراوند ويندو ستابيليا ستندوم كله زي ما حضرتك شايفين في الصوره يعني. انما حصل نوع من الكلاسيفيكيشن غير بقى سادي كلاسيفيكيشن وميركوتوس. الكاراكون في 1988 بدا يبص للريتراكشن بوكيتس بزاويه مختلفه. هل البوكيت ده موبايل ولا هو فيكست؟ كان يو سي ذا فاندس اوف ذا بوكيت ولا لا؟ وده مهم الحقيقه لانه ليه بيرنج على الانترفنشن او الديسيجن ميكنج اللي احنا هنتكلم عليه بعد شويه. وهو طبعا يعني لكن in any situation we need not to just look at the pocket but to look at the patient symptoms and the hearing status بتاع العيان and the status of the ventilation and other factors that would take it into account to make a decision على العيانين بتوع البوكيتس. الحقيقة has not taken into account the hearing status of the patient, whether the ear is discharging ولا لا, behavior over time. يعني البوكيت في بوكيت تلاقيه stationary وفي بوكيت الحقيقة بتلاقيه progressive. بتاع العيان او اذا كان في ديسشارج الكواليتي اوف لايف اوف ذا بيشنت. كل دي من الشورت كامينجز للكلاسيفيكيشن اللي اتعملت قبل كده. انما احنا في الديسيجن ميكنج الهيلينج ستيتس في ديسشارج ولا لا، والبيهيفير اوفر تايم، كل ده مهم قوي to tailor my management based on the patient's presentation اللي موجود عندي from the clinical point of view. العيانين دول بنعالجهم ازاي عشان الوقت؟ انت you may offer them كل ال 5 options اللي انا بقولها دي: watchful waiting, hearing aids, preventative cartilage, temporoplasty, ventilation tube insertion. دول الحاجات اللي هم هي طبعا كنت كمستيرتومي زمان كان في براكتس يمكن في فرنسا اكتر ان هم بيعملوا للناس دول كورتيكال ماستكتومي. I don't think it is actually being valid and practiced يعني nowadays. فاحنا عندنا الاربعه اوبشنز الاولانيين: watchful waiting, hearing aids, cartilage temporoplasty. دي وامتى بنستخدم دي بيعتمد على variables كتيرة جدا. يمكن ان الفيديو ده وقت ودي كان a young patient actually was like 21-year-old patient. وزي ما انتم حضراتكم شايفين كده في الفيديو الابروتش بتاعي كان بوست اوريكولار ابروتش طبعا. وانا بشيل البون اللي موجود على الاتك، وطبعا هنا الشيث بتاع الفايكل سوتشر بحيث ان هو يحمي لي السوفت تيشو، يحمي لي التمبانيك ممبرين والفلاب بتاعي عشان اوصل من غير ما يحصل نوع من التير للتمبانيك ممبرين او التمبانوميتال فلاب. وزي ما حضراتكم شايفين قدامكم هنا تيبس الستيبل سوبر ستراكشر قاعد زي ما هو. I'm lifting the يعني separation للميكوزال فولد اللي هو very close to the malleus. وطبعا الانكس كانت partially eroded اللونج بروسس بتاعها، فانا شلت الانكس وبعمل دلوقتي ديزاين او فاشننج ل حاجتين في الانكس. حاجه اسمها الاسيتابيولم. احنا بنعمل فاشننج للانكس على اساس احنا بنحط جزء منها يبقى على ناحيه الماليوس والثاني بيبقى موجود على الفوت بليت او الهيد اوف ستيبس يعني. فاحنا بنديزاين something like horseshoe بحيث ان هو يبقى fitting into the malleus، وثانيه بنعمل نوع من الاسيتابيولم to fit into the head of stapes. والاسيتابيولم عاده بعمله بالشورت بروسيس اوف انكس، انما البودي اوف انكس بستخدمه عشان اعمل الهورسشو to fit into the malleus يعني. زي ما حضراتكم شايفين كده الاسيتابيولم اتحط على الهيد اوف ستيبس، وطبعا الهورسشو انا طبعا عملت posterior malleolar relocation وبحاول to fit the malleus into the notch اللي انا عملته او الهورسشو اللي اتعمل. وطبعا زي ما انتم شايفين الموبيليتي موجوده، والحقيقه استخدمت بون سيمنت في الحاله دي تو فيكس ات مور، وبستخدم التريجل كارتليج عشان حاجتين. الحاجه الاولانيه ان انا تو فيل ان ذا جاب بتاع الاتيك اللي انا عملت اتيكوتومي عشان ما يحصلش ريتراكشن بعد شويه، وفي نفس الوقت تو سترينثن التمبانوميتال فلاب وبقيه التمبانيك ممبرين. And I'm using actually now the temporalis fascia over the cartilage itself برضو as a support للتمبانوميتال فلاب. يمكن في agreement في الليترشر على انه مهم جدا we must examine the nose في حالات retraction problems because nasal pathology is reflected on the ears and you cannot really manage the ears without considering the treatment for the nose طبعا. فدي حاجة مهمة جدا. الحاجة الثانية في حالات الافيوجن لما بيبقى عندك retraction pocket وافيوجن موجودين مع بعض معناه انك انت عندك an active disease that you need to really manage before going for surgery. في دائما في الموضوع ان الايرلي انترفنشن والهيرنج كويس بيبقى اسهل تكنيكالي بالنسبه لنا، لكن هو ريسكي طبعا لانك انت يميم في the patient's hearing more والعيانين ما بيقدروش الحكايه دي قوي. لكن برضه on the other hand wait and see policy may lead to extensive adhesions of the middle ear which makes the surgery much more difficult than if you started if you do surgery early in the disease. لكن هو ده it has to be taken into account في decision making process. I'd like to conclude by stating that the currently described staging system of retraction pocket leaves a lot to be desired for. It did not take into account the hearing status of the patient, the progression of the disease, which is really important in the decision-making process. A functional method of management of the retraction pocket consider not only topographic description of the tympanic membrane, إنما الإمباكت على الهيرنج بتاع العيان وطبعا الإير discharge إلى آخره. And I think we must really update the classification by taking all these factors into account to come up with a comprehensive classification that would serve the clinical needs of our patients. Intraoperative challenges. وكمان في post-operative challenges يعني. For classification purpose ممكن نتكلم عن pre-operative challenges لو عيانة pregnant would you do surgery للعيانة دي ولا لا؟ If you have an active disease would you operate on these patients? Would you start them on medication? Intraoperatively طبعا لو عندك narrow ear canal can you do it transcanal ولا لا؟ And how would you change your approach? طبعا في challenges في lifting the tympanomeatal flap وخصوصا لما يبقى الفلاب very thin. الحقيقة sometimes الفلاب بيبقى easily torn من الجراح ف it has to be really dealt with caution. Challenges lifting the annulus. Sometimes if you try to lift the annulus you may lead to actually perforation أو يعني to separate the flap, the tympanic or the ear canal skin from the tympanic membrane. You can have like a cleft between the two. Keeping the integrity of tympanic membrane, preserving coda tympani, ossicular chin testing, reverse technique, crural fracture. كل دي حاجات ممكن تحصل أو challenges أثناء الجراحة and how to deal with it. طبعا الكريمبينج process would you crimp ولا تستخدم البون سيمنت؟ لو عندك fallopian canal بتاع الفيشل nerve is in your way ناحية الأوفر window, what would you do if you have a biscuit foot plate, obliterative otosclerosis, floating foot plate, high jugular bulb, malleus fixation, tympanosclerosis? These are the issues that we actually encounter sometimes when we deal with stage surgery. So every surgeon of us, when he deals with or she deals with this condition, has to take into account that you may encounter these issues and you have to have a plan B to deal with the situation. Now, I know that some of us as ENT surgeons, we would not operate on patients who plan to get pregnant in future. No one would claim that I would operate on a pregnant lady. This is not going to happen to any of us, obviously, because it's the answer is no. We do not operate on pregnant ladies, obviously. But the question is, if the lady is planning to get pregnant in future, would you actually operate on her and let her get pregnant in future ولا لا؟ طبعا عندنا الحقيقة في ناس بترفض خالص يستنوا لما البيشنتس يعني finish their pregnancy ويعني حتى ان هم to have more babies وبعدين بيقرروا الجراحة. إنما الحقيقة evidence is not in favor of this. The evidence is that you can operate on patients and they can get pregnant in future. And probably the best answer comes from this study in laryngoscope. I know it gives really a good answer to the question that it would not make a significant difference to these patients to have further pregnancy. Some pills would you let them stop before you contemplate surgery? Again, the jury is out. If you have an active disease, would you actually operate on them? Probably I would wait to actually the disease activity subsides. But would you give the fluoride and vitamin D bisphosphonide? I think probably most of us will start them on these medications, particularly bisphosphonide. I think fluoride it has to be used with caution, particularly when they have renal issues, and because it's going to be used for a long period of time, and it may have some kidney drawbacks on the kidney. So if you were to operate on the patients and you go in and you find that the ear can you can do either. But I think all of us tend to actually operate on them through the pit. So this is a case of bilateral sclerosis, but this is the left ear, and that is the endoscopic approach to deal with this condition. Now, as you can see, using the blister D, would you make the vertical incision at 6 o'clock? Then another thing with the use of this round knife, we call it, or the Rosen angle knife. And you connect them, and you lift the tympanomeatal flap. Sometimes this is flatly torn. Mind you, this is called a vascular strip. It carries actually the blood supply to your flap. Absolutely, we use the local injection using saline adrenaline, for example. Be careful with it because it may actually lead to lip formation, and this flap can become very flimsy. Lifting the flap and you reach close to the annulus, be careful here, because you may just go in here, and this can create like a cliff between your meatal flap and the tympanic flap. So and you lift the flap in theory to the 6 o'clock. You make use of it, because you've already done your vertical incision. They got the include stapedial joint, and you carry on lifting the flap until you actually expose the malleus, because you need to test the circular chain, and in order to test the circular chain, you really need to expose the three of them. And testing the chain, you test the malleus, and you can see the movement in the incudostapedial joint, and that means actually the malleus is fine, the malleoincudal joint is fine, and that is the way you just remove this mucosal fold and you start testing the ossicles. You don't have to expose the malleus as in skeletonizing it from the tympanic membrane. I think probably just exposing it is enough. It's not like when you do tympanoplasty sort of thing. So you test the mobility, and then you actually check you can see that the incudostapedial joint is actually mobile now. So the next step is to actually check the stapes itself, stapes head. and then you cut the stapedius tendon, as you can see with the blue scissors now. And then you separate the inculuostapedial joint. That is the classic technique. But the reverse technique, if you can see the oval window or the foot plate, you may actually make your flestrum before cutting the stapedius tendon and separating the inculuostapedial joint. But sometimes you cannot see actually the foot plate without severing the stapedius tendon and disconnecting the inculuostapedial joint, as you can see now. So the reverse technique is not possible in every and each patient. Then you measure the distance between the long process of incus and the foot plate of stapes. And the next step is to actually, I would use the perfector here in Egypt, but if you have the laser available, probably it's actually the precision of laser is much better. But obviously, you use whatever tool you have available to, make this delicate incision. And then this is a Teflon piston. You actually deliver it into your field, and then you push it through this. Because now it tells me that 10 minutes are remaining. I'm going to speed up the rest of the presentation. This is a microscopic stapedotomy, but I don't think there's a time to actually go through that. Testing the ossicular chain mobility, as I shown in the video, you need to have the one we have here in Egypt actually is 4.5 millimeter long Teflon piston. In some patients, actually, the distance is pretty longer than this. So I think all of us need to have the longer prosthesis. And just in case if you have, this is really common syndrome in Holland, and they usually have a longer distance from the long process of incus to the foot plate. Now, if you have obliterative otosclerosis, you're unlucky. I think what we need to do is to use all what we have in our armamentarium to actually deal with this, be it the drill, the laser, or what you have in your tools to deal with it. And if you have a biscuit foot plate, preferably here is to actually use laser, because if you use the gel, you may have actually a floating foot plate. And if you have the facial nerve in your way, again, you may decide to abort the and whether you can do anything about it. And again, for the sake of time, I'm going to end here, and I would like to thank you all for listening. And I'm going to go for the next presentation. The critical appraisal of cochlear implantation. Which has been done about 4 months ago. This is an adult postlingual due to ototoxicity. The first thing to do is the surgical incision. Now, are you going to do a straight incision, a C-shaped incision, an inverted J incision? Or are you actually going to do the classic way of, like what we used in the past? What evidence do you have to do this? The second question is about the cortical mastectomy. Would you do it and leaving a cleft bone out, or would you actually sorcerize it? And the third question, would you do it through the posterior tympanotomy, or would you do it in different approaches? These are the questions that we need to look for in terms of the evidence. This is the left ear. I'm actually doing the posterior tympanotomy now. And again, when you do posterior tympanotomy, as you all know, one has to be really parallel to the important structures. The most notable of which is actually the facial nerve. And that is the round window. This is the round window niche there. I'm actually taking a lot of bone medial to the facial nerve. Some of us think once you open up the middle ear, that's fine. Actually, you need to take a lot of bone medial to the facial nerve to have good visualization and a good, comfortable angle of insertion of the electrodes later on. So you're drilling the over niche now. And what I actually, do is to lower the speed of the gel to like 5,000 when you reach this stage. And then you insert your electrodes. After you create your well, that is actually a well with a tunnel or a groove. And that is basically the electrodes to be inserted into the round window. This is really, now there is a trend now that most of the ENT surgeons will do round window approach. We used to do colostomy in the past, but not anymore. So the questions in terms of the surgery, which skin incision would you do? Would you do this one, or that one, or that one, or that one, or that one? What evidence do we have? Now, if we look in literature, we actually find that we need to consider the blood supply to the area that we are interested in. And we should not be near to the receiver stimulator when we do this incision. You need to plan it in advance to make sure that this is the case. And obviously, linear temporalis, mastocytic, and spinophilia should be accessible, particularly the root of zygoma as well. So the incision needs to take this into account: arterial supply, venous drainage. And that is probably what we actually do now. It's kind of a very small incision. You're talking about 3 to 4 centimeters, while in the past it was much more than that. So taking into account the blood supply, now the incision is more or less actually vertical incision like that, because you're not going to interfere with the superficial temporal, posterior auricular artery, and you're going to be parallel to them. So that is the chronology of these incisions. We ended up doing actually the invasive, minimally invasive incision now, and it's a straight incision, and that is probably the best of the best. And that is, there is quite a good evidence to the infection rate after the straight incision compared to the classic incision, as you can see in these tables, actually revising the whole literature about the complication following the various types of incisions. And there's a good article published it's an old one by Hussam Kashlan and Tillian, and it concluded that the infection rate is much higher than the extended post-auricular incision for the C-shaped incision. Anteriorly based flap versus superiorly based flap, there is no research done as yet to actually answer this question. Whether the flap that we do is anteriorly based or superiorly based, there isn't any study that has been conducted to actually give an answer to this. Doing well or no well, again the jury is out about this. Most of us would do well. Some of us will do suture. There's quite a lot of studies that are actually done all over the world that actually shows no significant difference between doing a well versus the tight subperosteal pocket. Would you suture or not? We don't suture anymore now. I think we used to do this when it all started. And as I said, the evidence is not really favoring any method than the other. To create a tunnel versus no tunnel, I looked at this myself in cases of bilateral simultaneous cochlear implantation, and there was no significant difference between creating a tunnel versus no tunnel, meaning like a groove. So fixation of the implant receiver would make no difference as opposed to not fixating it with a supraosteal pocket. Posterior tympanotomy versus suprameatal approach, I think the literature is definitely in favor of posterior.
شفنا بشكل
بالنسبه لما نتكلم على كوبيوستومي فيرسس راوند ويندو، الحقيقه الليترشر كلها يعني doesn't really favor one to the other، لكن هو الحقيقه في natural tendency all over the world دلوقتي ان الحالات دي بنعملها through the round window because it's more physiological. لكن in certain situations I think we as surgeons need to be trained to do الكوكليوستومي، وده طبعا مهم جدا لانه some patients you have to do cochleostomy if the round window is invisible. For example, لو عندك الjugular bulb is quite high almost obscuring the round window. In this situation we have to have this approach as cochleostomy technique يعني in our armamentarium when we deal with this condition. Would you do البيريمودايلر versus straight electrodes في الكوكلير implantation؟ هي في advantages و disadvantages لكل حاجه من دول. البيريمودايلر بيبقى very directly in contact مع السبايرال جانجليون، وبالتالي يعني الانرجي كونسومشن بيبقى اقل والتوصيل احسن. انما ده يعني ثيوريتيكال، انما الحقيقه في البراكتس it doesn't make any difference in terms of whether it's actually perimodiolar ولا straight electrode. لكن في الحقيقه البيريمودايلر بيبقى عندنا مشكله في الريفيجن. في الريفيجن سيرجري if you want to take out البيريمودايلر ممكن يبقى عندك issues في يعني tearing of the spiral ganglion. Plugging cochleostomy site ولا لا؟ يعني again there is quite a number of studies actually. One of them is said hearing preservation noticeably better when cochleostomy is sealed with soft tissue rather than with fibrin glue. لكن طبعا level of evidence as you can see is quite يعني low level of evidence. لكن I usually actually plug the cochleostomy a piece of muscle and just put it there. Hyaluronic acid I used to do it, I don't use it anymore. انما يعني in theory it facilitates الحقيقه الانسرشن بتاع الالكترودز وبتقلل الاير بابلز، لكن the level of evidence is not that high to actually support using it. Steroids, I use steroids in almost all the patients. As in oral steroids بيتاخد في intraoperatively، انما الانتراتيمبانيك injection of steroids I don't inject anymore. انما الحقيقه في level 3 evidence to support injecting steroids اثناء الجراحه. Does it make a difference in number of electrodes inserted في cochlear implantation? I don't think there's any answer to this question, and I don't think there will be any answer to this question for obvious reasons. لما نتكلم على ال 3 layers versus 2 layers flap، حضرتك بتاخد السكن وبعدين السوبرفيشال لاير بعدين وبعدين البالبا فلاب وبعدين بتخيطهم برضو كده اللي هم 3 layers. السؤال would 3 layers be better than 2 layers flap ولا لا؟ Again, I don't think there's any research being conducted to answer this question, so we need to think about it and probably try to do some research to come up with an answer. Plain X-ray, I don't do it. It is done primarily for medical legal reasons. انما وممكن تعملها طبعا لو انت if you are not sure انك انت inserted electrodes في حالات congenital anomalies في حالات post meningitic. انما straightforward cochlear implantation, you don't need an X-ray to prove that you are in the cochlea, because you know that you were in the cochlea anyway. I would like to end by thanking you all for listening. ولو في أي أسئلة يا دكتور إياد أو الأستاذ علي أنا تحت أمركم. Discharge meaning pulsating discharge with active inflammation. I think we should wait until this infection subsides, then operate on the patients.
Thanks. أسئلة ثانية. Another question, Professor Ali. For cochlear implantation, do you use or used to realize the undrilling or drilling of a bed for the implant? Okay, for the implant, for the device.
معلش يا دكتور اياد الخط بيقطع.
Do you realize in or drilling of a point for a cochlear implant device in your practice?
Yes. بص حضرتك when you do the cortical mastectomy, it depends on the anatomy. الحقيقة أنا بحاول أعمل زي بوكيت كده بحيث ان انا اعمل الكويل بتاع الالكترود فيه، يعني انيم الكويل فيه. It's like a bit for the electrodes الحقيقه. And sometimes you see an air cell cliff of bone فوقها، فده بيساعد جدا انك انت تعمل كده. I do this and I try to do this عشان ده برضه one of the methods to help fixing the electrodes in place يعني. So I do this sometimes.
Thanks.
Sir, do you use cortical mastoidectomy when you are dealing with retracted pockets, or only you reconstruct with the cartilage and the ossicles? Do you do cortical mastoidectomy? Do you use cortical mastoidectomy when you are reconstructing in the retracted pockets, or there is no need for that?